start of this session, move on to next presentation, Aris.
Yes. I would like to ask Thomas Gossios, a young doctor and recently elected professor, assistant professor in cardiology in the University of Thessaloniki. And he's actually a great collaborator with us in the network. And Thomas is going to talk about the Lamin, which is really a very challenging, cohort of cardiomyopathies.
Thank you very much for the introduction, Dr. Anastasakis. Dear colleagues, I'm going to be, unfortunately, Professor Nihoyannopoulos, I'm going to trigger the myocarditis discussion again. I know you wanted it to stop. So I'll be presenting a slightly unconventional Lamin patient. So I'm going to be speaking about our proband, who's the only patient I'm going to show you details of today. She's a 25-year-old, very fit female, athletic. She runs regularly, cycles regularly, does 10K runs regularly. She had the prior history of bulimia nervosa, but at the time that we saw her, this had resolved. So her history starts about 5 years ago when she went on a pre-participation screening ECG, went to have a pre-participation screening ECG before a run, and she had PVCs recorded. At that point, she didn't have any further workup, but later on in the course of her life, she felt an episode of retrosternal chest pain radiating to her neck that lasted for about 4 hours. She didn't seek any further medical assistance. Over the past few months, and the thing that brought her to us was that she had three recurrent episodes of symptomatic palpitations, and on some occasions she felt profound weakness with a sense of bradycardia. And there was indeed an ECG with sinus bradycardia documented. She has no history of syncope. Her CK was normal. That's the family tree. Sorry. So here's our patient. I'll just show you the family tree just to show you that her parents had normal screening after we saw her. Her sister and brother had normal screening. There is a sudden death at the age of 73 in her paternal great-grandfather, and also one of one of the siblings of her grandmother. But other than that, there are no red flags for Lamin in this family. That's her ECG. It's not perfectly normal, but perhaps I'm biased. Perhaps the V1 and V2 progression of the QRS in V1 and V2 is a bit slow. Her PR interval is normal. There's no repolarization abnormalities, but she does have ectopics. She had a Holter monitor, which showed that the ectopics were almost exclusively monomorphic. There were about 3,500. There were no complex arrhythmias, no conduction defects, or no pauses. There were some instances of sinus bradycardia down to 43 beats per minute, but other than that, there was no supraventricular or AF detected. For the sake of time, I'm skipping the echocardiogram. It was perfectly normal. And I'll show you that her MRI also, at least in the CINA imaging, showed normal biventricular function, no regional wall motion abnormalities, normal atria, normal valves. On late enhancement, however, she did have a patch of scar at the basal posterior and inferior wall. It goes around like this. That's it's slow. So at the basal wall, it sort of goes around. So we performed genetics, and we had two results: an Lamin pathogenic variant and a Desmoplakin variant of uncertain significance. Looking into these, the Lamin variant has been previously described. It does have fulfilled criteria to be considered pathogenic. On the other hand, the variant in DSE is likely benign. And given that we do consider her a Lamin patient, we had to estimate her risk. And she's overall a low-risk patient with a calculator that's specifically designed to estimate that risk, calculating a 5-year risk of sudden major ventricular events at 3.3%. So just to give some context to the audience, laminopathies is actually a family of conditions, not just a single condition. It's just that a major proportion of these involve the heart muscle, about 60%. But you can also get lipodystrophy, you can also get peripheral neuropathy, you can also get Hutchinson-Gilford progeria, which is a progeroid syndrome. And you can get mixed phenotypes. That's why all these numbers don't add up to 100%. So lamin is a gene that encodes two different proteins, lamin A and lamin C. They are exactly the same. It's just that the tail is slightly different. They are localized in the nuclear lamina, so they are involved in maintaining the structure of the heart muscle cell nucleus. And the rod domain is highly conserved. We discussed about conservation in the morning when Prof. Efthimiadis was mentioning the genetic part. So far, there are more than 500 pathogenic and likely pathogenic variants. The nuclear lamina, as I said, provides it's like a scaffold for the nucleus. It helps anchor the chromatin, and it has multiple functions that are related to DNA replication, transcription, organization of chromatin during meiosis, etc. Now, in terms of genotype-phenotype correlations, we don't have a very clear picture. Cardiomyopathy in general tends to cluster in variants that involve the rod domain, but there are also other factors weighing in the development of the phenotype, mainly epigenetics, but there's also regulatory genes and relative tissue sensitivities, for example, the sensitivity of the cardiac muscle versus the striated muscle. Now, specifically about cardiomyopathy, its laminopathies are inherited in an autosomal dominant trait, and they have some very distinctive characteristics. They are associated with conduction disease. So when we screen a population with AV block and dilated cardiomyopathy, about a third of them may present with a Lamin mutation. Overall, they constitute about 6 to 8% of familial genetic DCM, not overall DCM. And they have high penetrance, and that's what is strange in this family, because her parents, if one of them is a carrier, we should expect to see some features of the condition. There is variable expressivity, of course, within families. Some people may have milder disease, some might have more severe disease, and there are also features of striated heart muscle disease. Now, that's the unconventional part that we need to make a point about laminopathies, that usually in cardiac disease we have systolic dysfunction, and later on we have AF, and later on we have conduction disease and ventricular arrhythmias. In Lamin, it doesn't work this way. Usually, the arrhythmias and the conduction disease may come earlier, let's say, prior to the development of systolic dysfunction. So sudden death can occur with milder degrees of systolic dysfunction. When heart failure ensues, it's also quite aggressive, and many of the patients end up having resorting to transplantation. How do we explain these features? Well, we do know from histological samples that in laminopathies we tend to have fibrosis that's mostly localized at the septum and specifically at the AV node. So that may be an explanation of why Lamin does cause conduction disease. And we see that macroscopically sometimes on late enhancement. So more than half of the patients with laminopathies will not have any late enhancement, but if they do, there is a preference towards the septum, which is seen, again, doesn't work, I'm sorry, which is seen more. So you can see, usually late enhancement involves the basal septum. And that translates into a septal pattern in the ECG. And that's why I wanted to note your attention. It leads V1 and V2 in our patients' ECG. That results in early pacemaker implantation. And in the family history, we would expect to see a history of pacemaker implantation, ICD implantation, some people having AF or a stroke, some people having advanced or aggressive heart failure, but we didn't notice any of that, apart from the sudden deaths two generations before. It does have, carrying a Lamin variant does impact longevity, and heart failure is one of the main determinants of poor prognosis. We analyzed Lamin compared to other genes involved in dilated cardiomyopathy in this meta-analysis, and we found that carrying a Lamin variant is associated with a 5-fold risk of composite endpoint of both arrhythmias and heart failure, and that compared to Titin or not carrying a gene. And Lamin appears to be even more arrhythmogenic than the typical arrhythmogenic genes in Desmoplakin disease. So what advice should we give our patient? Can we do anything at this point? She's an avid athlete, so we took the advice from this paper from a Norwegian group that says that carriers of Lamin mutations do tend to develop their condition earlier if they do exercise. That's the epigenetic part of disease expression. So we advised her to avoid exercise. We calculated her risk, bearing in mind that it might change suddenly if we do pick up non-sustained VT or AV block on her Holter monitors, but for now she's considered a low-risk patient. And given the high prevalence of conduction disease, when you implant a device, at some point that device may start pacing a patient with systolic dysfunction, so we might need to consider upfront CRT implantation to avoid further deteriorating LV function. Unfortunately, these patients also have poor response to treatment. Out of this analysis by Escobar Lopez and his team and their team, we see that desmosomal and nuclear envelope proteins are the ones who have the poorer response in terms of reverse remodeling to conventional treatment, heart failure treatment. And I talked about risk. We know what risk factors are. Risk stratification has slightly changed over the years. Initially, we had these risk factors: non-sustained VT, a low ejection fraction, male gender, and non-missense mutations as risk factors. And it was like the typical HCM risk stratification. The more risk factors you have, the more at risk you are. But now we're making calculators for everything. So there's a new calculator that involves exactly the same risk factors. On top of them, we also added, together with Karim Wabi in this paper, the AV block as a risk factor. And another thing we should keep in mind in these patients is that they are at increased risk for thromboembolism, even during sinus rhythm, compared to other dilated cardiomyopathy patients. And the reason for that is because Lamin affects electrical conduction through the atrium, and it results in atrial standstill. So someone may be in sinus rhythm, but their atrium does not contract. That's why we have evidence of early of detecting this early with strain, LA strain. That could be a risk factor, a risk marker, a marker of advanced risk for thromboembolism, so we can preemptively introduce anticoagulation. Now, overall, my impression, at least of this case, is that it's a less typical form. There's no red flags here. There's an atypical late enhancement location. And given the history of chest pain, could that be a myocarditic episode, or not just a myocarditic, but a flare-up of the condition, a phase where the condition advances? I told you about the management plan. Our main goal right now is to convince her to stop exercising. She's at low risk, so we're not doing anything more, and there's no evidence that preventative therapy could help. We have proceeded to cascade genetic family screening, but unfortunately I don't have the results yet. But at least on a clinical basis, there's no evidence of anyone having the same background, or at least, the same phenotype. Could that be a de novo variant? That's for us to tell you later on once we have the results. Thank you very much.
All right, Dr. Gossios, very nice presentation. I would like to ask you, I don't know if there is any question from the floor. Okay, I want just to make a comment about all these risk stratification models that we use. There is although a difference between the model that we first used in hypertrophic cardiomyopathy in 2014, where there we predict sudden death, although here, in these models, they predict ventricular arrhythmias.
It was major arrhythmic events, including sudden
But
death.
they don't say sudden death. They say, I don't know, Bill, if this makes a difference. If there are different risk models, I mean, or is the same thing. When we say ventricular tachycardia or ventricular arrhythmias, does this mean necessarily sudden death?
Depends on the disease. So, if you have sustained monomorphic VT,
Ένα μικρόφωνο μπροστά.
other than from the apex and hypertrophic cardiomyopathy, that's probably going to be a lethal event. In contrast, with a ARVC with Plakophilin mutation, most of them have lots of episodes of sustained. You can have patients who've had multiple episodes of sustained monomorphic VT at 200, 220 beats per minute. And in the models, the Casman-Turini with Plakophilin 2, Hopkins and Utrecht group, they have a pretty stringent diagnostic criteria. I forget, but it's a VT of 230 a minute or something. You would think that would be fatal, but in ARVC, it tends not to be. So most of the patients we've had with Plakophilin 2 have had multiple episodes. In contrast, I don't know about Lamin, but in contrast, in hypertrophic cardiomyopathy, unless the VT is from the apex, and if it's more than 180 to 200, it's usually fatal. And you see that on the, not always, but usually, and you can, now that you've got ICD discharge, ICD data to look at, you can actually characterize.
Yes, but what I mean is that in the first model, hypertrophic cardiomyopathy model,
No,
we are talking about the event of sudden death.
Yes.
Here, it's not exactly the same.
No, and it's not the same. The different models have different approaches relative to the disease. And I get what is the right approach for Lamin, I'm not sure. But your point is correct, that it should be more specific to the disease, and the definitions should be very clear. In ARVC, it is very clear. I don't think they're all lethal, but it's very clear what it is.
Okay, and my question is, are we able at the moment to trace differences in natural history of these different cardiomyopathies? Let's say Lamin cardiomyopathy and Filamin cardiomyopathy, and Desmoplakin cardiomyopathy. What is the difference of natural history of these entities? Are we able at the moment to
I don't think
say
there's any
this, to
comparative
describe this?
data, Prof. What we do have is a good description of each individual phenotype. So there's papers on BAG3, there's papers on RBM20, there's papers on Lamin, but there's very few data on comparative. That's what actually drove us to do that meta-analysis, to figure out if there's any differences. We call everything arrhythmogenic cardiomyopathy, but it is having a desmosomal mutation different to Lamin.
Yes.
Definitely, yes. But we needed to have some evidence of something visualized.
So Lamin is one of the ones where we probably have more information. It's inadequate data sets, but we do have more data on Lamin going back. I mean, it was a risk model 7 or 8 years ago. It was incomplete, but there was a model. In Health and Code has a database of roughly 45,000 gene tests, and I forget roughly how many Lamin are, but there's a lot of them Lamins, and it's quite clear in the survival curves. It's not until your third decade that the deaths start to happen.
Yeah.
So you have, say, in the risk model, your male, non-sustained VT, and a mutation, and I forget the other one. And basically, do I put the ICD into the 18-year-old? No, not when he's 18, because he's very, very unlikely to have an event. So you need to personalize the ICD decisions in relation to the outcomes, and we don't really have enough information, even on Lamin, but we do have Lamin, and the females don't start dying suddenly for at least a decade later. So, for instance, yes.
All right, so Professor Katsoulis.
If there is so much confusion about what to do with potentially malignant ventricular arrhythmias, that's what you meant before about ventricular arrhythmias. I mean, non-sustained VT. How long, how many, how fast, and so forth. Why not using the real test that can distinguish the severity of the ventricular arrhythmias, the electrophysiological study? I don't understand that. Especially I'm confused by the fact that 2022 guidelines for ventricular arrhythmias generally introduced the concept of having EP study with generous program ventricular stimulation in DCM cases more than 35% if they have unexplained syncope, difficult there. Some people think all the syncopes are hypotension, some other people think all the syncopes are hidden malignant ventricular arrhythmias. And if they're Lamin AC with ejection fraction 50% and specific other gene types among DCM patients, to go after EP study. 1 year later, the Myocardiopathy 2023 guidelines talk about the same thing but avoiding the EPS. Can you give us an explanation for this kind of confusing statement?
I think the reason for that is that we're moving towards a more gene-focused risk
But you are
identification.
confused. You have so many variables.
Which is non-invasive as well. You're right. I think
You think that the non-invasive with the artificial intelligence will give the solution?
I think we should refine.
This is a very good thing. Computers have made a major impact in our lives from every point of view. But we have to introduce the right data. Because if we introduce the wrong data, they're not going to be very useful. Profit has solved that recently in the European Heart Journal, that not even magnetic resonance can help identify the real post-MI high-risk patients.
Okay, Kostas, thank you very much for your views, and we have to go further now.
I would like to